Murphy's Law. Anything that can go wrong will go wrong. The emergency department is sometimes a perfect example of Murphy's Law. I'll be at work just having a good ass day. Sunshine and rainbows, my guy. Sunshine and rainbows. Then all of a sudden, either a nurse, medical student, or resident will go ahead and say, "Man, it's so quiet." Oh my gosh. Like clockwork, and all of a sudden, we get a gunshot wound, pregnant patient actively delivering in the lobby, anaphylactic pediatric patient, a car accident versus a bus rollover, and 10 patients that come in with cough, runny nose, and belly pain all walk into the emergency department like a coordinated attack on the ED. I swear, if you want to make friends in the ER, be that guy. Just be that guy or gal. And say something like, "Oh, it's so quiet." Or, "Where are all the patients?" That's pretty much just summoning Murphy's Law. Anything that can go wrong will go wrong. That's a pimp question. That's a pimp question. I'm just kidding. It's not a pimp question, but you definitely need to know. And if you want to make some friends in the ER, I just tell you, don't go around saying it's quiet. Anyway, today we're going to be talking about cholecystitis. Cholecystitis is actually pretty common. What is cholecystitis? Well, let's break this down. Chole comes from the word bile, cyst from the word bladder. So we have a bile bladder, and itis is inflammation. So we have inflammation of the gallbladder. Now, the gallbladder is a small organ that plays a huge role in the digestion of our food and storage of bile. Bile is pretty much allows us to digest food. Quick little anatomy recap. The gallbladder is that pear-shaped organ located beneath the liver. Its primary function is to store and concentrate bile produced by the liver. Bile is essential for digestion and absorption of fats in the small intestines. And the gallbladder contracts in response to any fatty foods. So those French fries, those greasy foods, your gallbladder is going to be contracting, pushing out that bile. So there's actually a few different types of cholecystitis. We have our calculous cholecystitis, and the most common cause of cholecystitis is the presence of gallstones, which can obstruct the cystic duct and lead to inflammation. Pretty much what happens is the gallstone blocks bile from coming out the gallbladder, and because of that, the gallbladder's trying to build up pressure, gets ischemic, and is more conducive to infection. Then we have acalculous cholecystitis. So this typically occurs more commonly in critical ill patients, such as those in the ICU, may develop cholecystitis without the presence of gallstones, and it's more common in the elderly, ICU patients, or even AIDS patients. Pretty much ischemia and infection, reduced blood flow to the gallbladder, and secondary infection contribute to acalculous cholecystitis. So what are the symptoms of acute cholecystitis? Well, patients often present with right upper quadrant pain, which can radiate to the shoulder or the back. It goes to the shoulder because of referred pain. Patients can have fevers and chills, and they could have a Murphy's sign. What is a Murphy's sign, you ask? So we're asking the patient to take in and hold a deep breath while palpating the right upper quadrant. If pain occurs on inspiration, when the inflamed gallbladder comes down into contact with the examiner's hand, that's a positive Murphy sign. Now, we do have chronic cholecystitis as well. It's much milder symptoms. Patients with chronic cholecystitis may experience less severe and recurrent symptoms. And then there's also biliary colic. and thus the intermittent episodes of biliary colic are characterized by pain after meals. Pretty much the gallstones are briefly blocking the cystic duct, but the gallstones eventually move out the way, and we no longer have the pain. Now, there's multiple risk factors for the development of gallstones. Those include, but are not limited to, being female, being a little hefty, being fertile, being 40, and having fair skin. That's why we call it the 5 Fs. Fat, female, fertile, 40, fair skin. Additional risk factors for gallstone formation include family history, certain medications, and prolonged fasting or rapid weight loss. But how do we diagnose cholecystitis? Well, there's a few things. From a laboratory standpoint, the liver enzymes can oftentimes be elevated and may be indicative of biliary obstruction. And in a CBC, you might see the patient having a leukocytosis or an elevated white blood cell count. From an imaging standpoint, ultrasound is the gold standard. Ultrasound is the first-line imaging modality for cholecystitis, and the ultrasound findings that we might see are gallstones or sludge, biliary sludge, or pericholecystic fluid, and the gallbladder wall may be thickened, which is technically greater than 3 millimeters. Or the common bile duct is dilated, which is greater than 6 millimeters. Going back to that Murphy sign, you can have a sonographic Murphy sign, and it's pretty much pain is reproduced when the ultrasound probe applies to the area of the gallbladder. Now, if a ultrasound is negative but suspicion remains high for cholecystitis, you always can do a HIDA scan. And that assesses gallbladder function and can aid in diagnosing acalculous cholecystitis. HIDA scan has the highest sensitivity and specificity for cholecystitis. You might ask, how is a HIDA scan actually completed though? So pretty much during the HIDA scan, a camera takes pictures of the gallbladder after a radioactive tracer is injected into the bloodstream. The tracer travels through your liver, your gallbladder, your bile duct, and small intestines. And failure to obtain an outline of the gallbladder within 1 hour confirms the diagnosis of cholecystitis. But if you're able to visualize the gallbladder and the common bile duct within that same hour, then the test is negative. What's the treatment for cholecystitis? Well, we're definitely going to make the patient NPO and give them fluids. A little LR bolus or a normal saline bolus. Fasting and intravenous fluids help alleviate symptoms and prevent complications. We also want to give them some analgesics for pain control, possibly some antiemetics as well. Now, oftentimes, if the patient's having really bad cholecystitis, cholecystectomy is needed. And if we break this down again, we have cholecyst, so bile bladder, ectomy is removal. So definitive treatment for cholecystitis involves the removal of the gallbladder, either laparoscopically or through open surgery. And you can do percutaneous cholecystotomy. Now, there are several complications that you do need to be made aware of. That could come up as a pimp question. They might ask, what are the complications of untreated cholecystitis? Well, one of them is gangrenous cholecystitis, and that's severe cases can lead to gallbladder necrosis and perforation. That is bad news bears. Patients will get real sick. The other one is an empyema, or pus accumulation within the gallbladder can result in empyema. And you also can have a bile duct stone, common bile duct stone. And stones can migrate to the common bile duct, causing obstruction as well. We have the emphysematous cholecystitis, is also a rare variant. Its commonly isolated organisms include Clostridium, E. coli, B. fragilis. Those are all pimp questions, but the diagnosis is confirmed with ultrasound showing air in the gallbladder wall. And this is a true surgical emergency due to the risk of gallbladder gangrene and perforation. This pretty much runs down all of cholecystitis. I can't think of any other pimp questions that might come up. That pretty much does the job. Just a quick pointer. If you're ever in the emergency department, don't be that guy that says the Q word. Don't be walking around saying, oh, the ER is so quiet right now. It's so quiet. Oh my gosh. We don't need Murphy's sign and we don't need Murphy's law. So, if you think it's really quiet in the emergency department, just keep that to yourself. Because I tell you, last time a resident came in and I was sitting at the desk, just minding my business. Once again, having a good ass day. I'm a cool dude. And then this resident or med student just walks up and talks to the nurse behind me and it's like, oh man, it's so quiet. I hope it gets busier. It's so quiet right now. So quiet. I was like, nurse, is room 3 open? Is room 3 available? And she's like, yeah, why do you ask? And I'm just like, well, me and this med student are about to throw hands because he's just walking around throwing quiet around all willy-nilly. And he's going to need bed 3 in a minute. So, because we're about to throw hands. Catch me outside. I'm just joking. But for real, don't be doing that. Don't be doing that. Don't be that guy. Don't be that guy. As always, keep your head up. You're doing great. You're better than what you were yesterday. That's a lot. Learn something new today. Gonna be a great doc. Sometimes you just gotta hear that.